You're listening to The Pelvic Messenger, hosted by Dr. Amy Stein and Dr. Corey Hazama. Presented by Beyond Basics Physical Therapy.
Hi, I'm Dr. Amy Stein, owner and founder of Beyond Basics Physical Therapy in New York City and author of Heal Pelvic Pain and Beating Endo. And I am so excited to have Dr. Rachel Rubin, who I've known for a very long time through ISHWSH, which is the International Study for the Society of Women's Sexual Health. And we are going to be talking about our topic of the intersection of hormones, pelvic health, and sexual function in women. So for those that don't know this wonderful physician that we're all listening to today, can you explain a little bit about your background?
Yeah, absolutely. I'm so thrilled to be here. I've been a big Amy Stein fan for I think as long as Amy Stein has been around. I am a urologist. I did my fellowship training in something called sexual medicine, which means I take care of all genders and I deal with issues of libido, arousal, orgasm, and pain. And so we do a lot of hormones and menopause. We do a lot of just sexual health. We do a lot of education, advocacy, and research. I started my own practice about 2.5 years ago in the Washington, D.C. area, although we just opened a clinic in L.A., so we are now bi-coastal. My co-fellow, Ashley Winter, has just joined me and is going to be seeing patients in L.A., and so we're growing just a team that really deeply cares about people and spends a lot of time with them. And so a lot of doctors don't really spend time with you, don't get to know you, don't really care about your goals and what you want, and especially when it comes to sexual health and quality of life. And so we do things differently, and we are just having so much fun.
Oh, that's awesome. And I'm a big fan of you always for as long as I've known you as well as Dr. Winter. So that's so exciting. Congrats. That's really exciting. So I am noticing your necklace there. Can you first describe to everyone what that necklace is?
Yes, I joke. I wear a clitoris around my neck. It's a custom-made clitoris. A wonderful artist, Sophia Wallace in New York City, does custom design clitoral necklaces, and this one has my birthstone, a sapphire, in it. And no one knows and really knows the true anatomy of the clitoris. So if I'm with politicians, they think it's just a nice piece of jewelry. They have no idea that I am literally talking about female genitalia.
Yeah. Actually, this wasn't part of our questions, but can you explain a little bit about why we only see a tiny portion of it visibly, but what you just showed us?
Yeah.
Because I think that's fascinating.
Yeah, it's really fascinating. So, I'm a urologist. I am a penis doctor. We have a whole field of medicine devoted to the male penis. And yet no one even studies or examines or cares at all about the equivalent of the penis, which is the clitoris. The clitoris and the penis are exactly the same thing. They're made up of the same tissue. They have all the same parts to it. It's just that the penis, half of it's outside the body and half of it's inside the body. And the clitoris, most of it's inside the body. So I have a vulva here. I should get one that's not clear, but basically, you've got labia majora, you've got labia minora, these inner wings. And if you follow these labia minora, you get to the hood of the clitoris. It's actually covered, essentially the same as men who have foreskin. It is the version in women. And so you should be able to pull back that hood and see the head of the clitoris like the head of a penis. But about 23% of women, it's stuck together, or what's called a clitoral adhesion. And we've done a lot of research on that as well. But the rest of the clitoris, this big organ, is all underneath the skin and the muscles and the tissue. And so you have to activate it in different ways. So the clitoris, like the penis, has a shaft, it has a body, it has legs that go all the way down to the butt bones. So you should be very familiar with the pelvic floor because Amy Stein, she basically invented the pelvic floor. But the clitoris goes all the way down to the butt bones. And so many people have to activate the clitoris to have an orgasm, need stimulation either externally up here or with vibration over the labia majora. Now, some people like inside or vaginal stimulation because that gets to the underside of the clitoris. But we know that less than 15% of women can orgasm from penetration alone. And so that's why you have to know where your clitoris is and how it functions to properly activate it. But it gets erect the same way a penis gets erect. It stimulates the same way a penis stimulates. It's just we don't really think about it that way.
Yeah, those are great points because I'm sure you have the same experience that some women at all ages, they come in and they're not sure where their clitoris is, and they may think it's the urethra opening or another area within that area. And so it's really important to educate for sure. Can you explain a little bit more about like how you would actually treat? Again, we're going a little bit off of topic, but we'll get to the hormones. But this is all part of the sexual health, pelvic health part anyway. But can you explain a little bit more of like how you would treat someone that has those adhesions that you're speaking of?
Yeah, it's really interesting, right? So the hood of the clitoris, I always wear sleeves so I can kind of show this. Is this do people see the video or they only hear the podcast?
Actually, both. We have
Okay,
it
good.
both.
So if you're listening to
will
it, but
just
you
see
want to
here.
see the visuals, I just showed some diagrams and some models and stuff like that. But if you think of my sleeve as being completely covering my fist, right, that's what a clitoris with a hood sort of looks like. And you should be able to pull it all back and see what looks like the head of a penis that has a rim around it. That's called the corona. But what happens is about 23% of people, it's stuck. And it may be mildly stuck where you can see most of the head, but it's stuck on the edges. It may be moderately stuck where you can see a sliver of the head, but it's pretty stuck together. Or it could be so severe that you really can't see the head at all. And 23% of all women have this. But here's the problem, my friends. No doctor on earth is taught or ever examines this part of the body. It is not a routine part of the physical exam. In fact, when I was in medical school, which wasn't that long ago, okay, let's be real, I have a lot of gray hair now. It was a long time ago, but when I was in medical school, we were taught don't touch the clitoris because you don't want to make your patient uncomfortable.
Right.
That's a no zone. So we
Right.
don't even teach doctors even how to look at it, which means if something goes wrong, who do you go to help you when something goes wrong? And so we are the first, group to publish on this really. And we continue to publish on it because it turns out when you get rid of those adhesions, you can improve orgasm, you can improve arousal, you can improve satisfaction, and you can decrease the pain because a lot of women, when it's stuck together and they get that erection, it hurts. It doesn't feel good. So how many women are walking around saying, ooh, I don't like oral sex. Ooh, I don't like when my partner touches me there. It doesn't feel good. Everyone assumes it's your psychosocial traumatic upbringing, and nobody says, look, there is oils and skin cells that build up underneath, and it's irritated and it hurts. If you ever wake up, with eye crusties, you've got these eye crusties and you just kind of pick them out and like you got to kind of separate your eye to open it in the morning. It's essentially the same thing that can happen to the clitoris because these oils and skin cells can kind of build up underneath. But no one's looking, you guys. No one's looking under the hood. So that's why you got to get your mirrors out and you have to start knowing what's going on down there because that part of your body is supposed to give you pleasure. It's supposed to give your partner pleasure. Like sex is literally how we procreate as a society. So we got to start talking about it.
I agree. And that's also an interesting point about how you're not educated on it because when I first started pelvic floor PT, I was also like, stay away from that area. You can look, but don't touch type thing. And same with our male patients, penises, like look, but you can, well, I was even taught like, don't even look, but now it's like, okay, there could be adhesions
It's
even
muscle.
in our,
it's muscle, it's tissue,
muscle.
it's connect, like it is part of the body. So again, the more we understand that these parts are just body parts, like anything else, we really can start to learn about them.
Yeah, totally agree. So can you explain more about the role of the different hormones in sexual function, estrogen, testosterone, progesterone, and any others? It's probably a whole hour topic in itself, but I've learned a ton from you, and I would love our listeners to be able to hear what you have to say.
Yeah. So, I think the more we learn, the more we know, the more we obviously have to understand that there's a lot we don't know. But as far as we know today, right, the ovary does three things. It makes estrogen, progesterone, and testosterone. It probably does a whole lot more than that, but we'll keep it simple. And so throughout your reproductive time, so when puberty happens, you get a surge of hormones. So little kids don't really have high levels of hormones fluctuating in their body. And then puberty happens and their bodies literally morph. Their genitals actually change. So little girls have no labia minora, and then they go through puberty and they grow big labia minora. The clitoris grows. The opening, when little girls, you couldn't put a tampon, in a little girl, and then they grow and puberty happens, and it's a place where tampons can grow because the whole tissue is very hormone sensitive. And so puberty creates all these changes in breast health. Teenagers are these horny individuals who have high sex drives. They may have acne and oily skin, but they learn about masturbation and they start exploring their bodies and they can orgasm, and all these things are happening because of a surge in hormones. And so so hormones are really important for sexual health. And so there is a biological basis to sexual health. In fact, many people will notice that around ovulation time, they get this surge of sort of, ooh, I'm interested in sex. And it's because the body has a little surge of testosterone to say, hey, go make a baby. Now's the right window. And so hormones are really, really important for sexual health. But we do a lot to mess up hormones or to play around with hormones. And I say this all the time. I'm a kind of a broken record. But when you play with hormones, there are consequences, sometimes really good ones and sometimes really bad ones, but there are always consequences. So if you're on a birth control pill, that can be great for not having a baby, which is a pro if that's what you want. But it may cause some lowered libido or some pain with intercourse because of the way birth control pills interact with your testosterone levels or lower your testosterone levels. And so there may be any kind of changes in hormones can affect your sexual health. We just published on a groundbreaking paradigm shift of when you are lactating, you develop genital and urinary symptoms around breastfeeding and lactation, which we're calling GSL, or genitourinary syndrome of lactation. Because when you're breastfeeding, you have menopausal level of hormones. They go very low. And so you get low libido, you get pain with sex, you get urinary tract infections. And then we know in menopause or perimenopause, these hormones are really fluctuating. And so again, it's going to affect your urinary health, your sexual health, your libido. And so we love to talk about the psychosocial effects of sexual health. And listen, y'all, everyone benefits from sex therapy and pelvic floor physical therapy. There is no human on earth who cannot benefit from sex therapy and pelvic floor physical therapy. I always say, Amy, if you have a pelvis, you should go to a pelvic floor physical therapist. And so, but there is so much biology as well. And that is sort of that third part that people like to minimize and also make women think that it's actually not important. And it is so important. And the reason Amy has me on, thank goodness, is because she learned early on, way ahead of most physical therapists, actually, that her job is so much better when she involves mental health and biological health in the pelvic floor world. And so that's where that trifecta is the magic sauce that we find.
Yes. So true. I appreciate the comments about the physical therapy, of course. And then it's so important to have you involved in these scenarios, as you said, the biology part. Is there like a test that you do for these patients for hormones, like to see what's going on with the hormones so that they understand more of what's happening in their body?
So more important than one blood test is education, because your hormones are changing long before your periods stop. Your hormones are changing long before the numbers and the lab values are changing. I was just texting with my friend who's a very popular Twitter urogynecologist, and she very publicly had an ovary removed from an emergency surgery. And she said, man, I haven't been feeling right the past couple of months, and my numbers, my labs are fine, everything's fine. But I put an estrogen patch on, and holy hell, it's like I can see color again. She said this very publicly on the internet. And I said, oh my God, it's a perfect story, because so the numbers did not reflect what was going on. And yet when you listen to the person and you listen to the symptoms and you give the right treatments, magic can ensue. And so it's a little more complex than, oh, I did a blood test, I don't qualify for this. There's a lot of nuance. So it's not that we never get blood tests. We use blood tests as a snapshot. But what's so fascinating about perimenopause is that your blood test one day may be completely different 2 days later. And so it's not completely explaining everything that's going on in your body. And unfortunately, right now, we don't have a continuous glucose monitor type of thing for hormones. Maybe one day we will, and maybe one day we'll get more data from something like that. But it's really important to know that just because your numbers look quote unquote normal, or your doctor won't even get them, your symptoms are real. And it's real if you're not feeling like yourself and you're feeling like you're falling apart. Those are hormonal changes.
Yes. So basically what you're saying is you really have to listen to your patients and not just rely on tests.
You have to see a doctor who will take time to listen to you, and also not just look. This is okay. Y'all, medicine is so broken, right? So we are taught in medicine, this is real, that you're only supposed to have one problem, right? If I I just went to a dermatologist. It was the worst visit I've ever had in my life. And I went for a skin check. But I also have want to know what I should be putting on my face. And I also have a question about a rash I've been having. And also I want to talk about this other thing. Well, she was only there to do the skin check. And my even bringing up another skin problem was like I was, an insane person, right? And she was out the door, and she knew I was a doctor. That was the craziest part of the story.
Yeah.
But the point is, a doctor wants you to have one problem. But in perimenopause, you don't have one problem. You have dry eye, you have headaches, you have heart palpitations, you have frozen shoulder, you have a dry vagina, you're getting urinary tract infections, and you don't feel like yourself because you actually do have one problem, but your doctor didn't learn that perimenopause has treatment options, and they can actually talk to you and explain to you what's going on in your body, because we don't teach doctors about menopause.
Right, right. So on to another area of topic with hormones is how would you explain that hormones affect the pelvic floor muscle function?
So this is really important. All muscles need hormones. And so think of bodybuilders and testosterone. Think of old ladies who the wind blows and they break a hip, right? And they fall over and they have sarcopenia, or they have very thin muscles. So hormones are really important for muscle health. And so that is probably a combination of hormones, but we know testosterone plays a very important role in muscle health. And so I see a lot with patients, if we put them on testosterone, it actually not only helps their pain with sex, but it helps their stress incontinence, because the pelvic floor muscles tighten. We need to write about this, by the way. A mild stress incontinence is made better with systemic testosterone. I'm officially comfortable saying that out loud. And so hormones matter for the tissue, but they can also matter for the strength of the muscle and your ability to strengthen pelvic floor muscles. I'll ask you, I mean, you have done this for so many years, Dr. Stein. What is your experience with the patients who are not on hormones versus those who are? And then what you see as they start hormone therapy, how their exams, whether it's local hormone therapy just for the tissue versus whole body hormone therapy for their menopause symptoms.
I have seen that. I have to say I've had more experience with the local, and then learning from you the ET cream, estrogen testosterone cream. I'd be interested, after I answer this question, to hear more about the systemic effects of the testosterone. But it does, to me, it makes sense from a muscle point of view. And then with the physical therapy, it definitely helps with the pelvic floor rehabilitation of the muscle and trying to get them stronger, for sure. So there definitely is a positive effect of doing the two at the same time.
I would say that you and some of your colleagues in this space who've been around a little longer than some of the newbies, I don't think they know how pioneering it was for you all to make that connection between the hormones. I remember even when I was in fellowship, which was 2016, so it wasn't that long ago, that it was unheard of for a pelvic floor physical therapist to think about hormones, to talk about hormones, to recommend hormones. And we were I remember doing courses with some of your colleagues. It was like we were crazy people of really trying to educate the pelvic floor physical therapist. And now Thank goodness, like you all became leaders in the space, and it has completely transformed in just a few years, which is so amazing to see.
Yeah, yeah, it's been wonderful to see, but we have so far to go still, you know. So can you explain briefly, like the difference between estrogen testosterone cream versus more like oral medication, but also maybe just give a brief on like what exactly is estrogen testosterone cream? Because most of the OBGYNs here in New York, they still mostly just prescribe like estrogen.
So we have a lot of work to do in this space because we've known about this for a long time, but there's not enough. We're not loud enough, right? We're not loud enough about this. And so there is data, there's research, there's published papers. But if nobody reads your published papers, it really doesn't get you very far. So what we're talking about, I think we need to go a step back. Okay. So you have hormone receptors in all of your body. You have estrogen receptors in your brain. You have estrogen receptors in your skin. You have testosterone receptors throughout your body. And so it's everywhere. And so we know that the vulva and the genitals are very hormone sensitive, both to estrogen and testosterone. And so what happens when there's an altered hormone state? Now that might be birth control pills, which lower testosterone in everybody, because birth control essentially shuts down your ovaries, so you're not making testosterone, and it often adds back estrogen, fake estrogen and fake progesterone, but it's not adding back testosterone. And so not having testosterone around really depletes the tissue of what it wants. And so it gets dry, it gets irritated, it gets uncomfortable, it throws off the pH. And so what we see clinically, Dr. Stein and I, what we see clinically is women come in saying, sex hurts. We're getting urinary tract infections, but the cultures are negative or the cultures are positive. I can't put tampons in anymore. Everything's uncomfortable. And what we see on exam is inside the labia minora, inside this tissue right here, it is like raw hot chili peppers to the touch. And that tissue is called the vulvar vestibule, and it's the most common reason we see people have pain with sex of any age. It happens commonly in menopause, it happens commonly in women on birth control pills, and it happens commonly in women who are breastfeeding and postpartum. And so what we have found is it's often a hormone, not always, but often a hormonal problem, right? Is because they are not getting the proper hormones in this tissue. So for someone on oral birth control pills, we tend to get them off oral birth control pills. We like hormonal IUDs because they don't stop ovulation. We like to add back hormones. So a mother who is breastfeeding or a menopausal woman, we like to add back hormones. And you can add back hormones locally to the tissue without affecting the whole body. So we often do whole body hormones, like for hot flashes and night sweats and osteoporosis prevention. But we find and those are awesome for many people. I'm a big believer in whole body hormones, but they actually aren't always enough or often enough to heal the local tissue at the opening. And so what we have found, there are a number of tools that we use to try to replenish the tissue with hormone. So vaginal estrogen is more commonly talked about and more comfortable in this space, and it works for a lot of people. And there's a little different forms. There's creams, there's inserts, there's rings, there's different forms of vaginal estrogen. And it can work fine. There's some studies to show that it actually can help with that vulvar vestibule pain. But what research of some of my colleagues have shown over many decades now is that tissue is actually really sensitive to testosterone. And so estrogen is not always enough. And so unfortunately, we don't have an FDA approved product, which is what it makes it difficult to teach your general OBGYN. We've had to learn and extrapolate. And so it's one of the few areas where I compound products. I don't like compounded products for whole body hormones. I only use compounded products when I have to. And here's a situation where I kind of have to. And so we take a minuscule dose of estrogen, like in an estrogen vaginal cream, a 0.01% cream, and we take a minuscule amount of testosterone. We use a 0.1% testosterone. Now, when I give women testosterone for their libidos, and I do that a lot, people, I do a lot of higher dose testosterone for libido, it's 1% testosterone. What we use in this compounded cream for this local area is 0.1% testosterone. So it's 10 times less. So it's not going to help with their libido. And that's a whole other product that we use. but it will help locally at this tissue heal it. And again, Amy can tell us what she sees in her pelvic floor world. She sees magic, which is why she's such a believer. So we use a local compounding pharmacy. It's funny, the guy has just been with us for so long that we know his formula. He knows us. We know him. I think he makes like witches brew vats of it because they're like, I think everyone in DC puts this on their genitals. And like, he's like, that's how I picture it. It's like a cauldron and he just gets the exact dose right. A pinch of this, a pinch of that. And so he puts it in these twisty things, and you twist it and you get a little gel here. You put on your finger and you rub it in. Again, I don't like compounded clicky products when you're treating your hot flashes. I like FDA approved products. But here is one place where we actually don't have an FDA approved product. I know I went long winded there, but I think it's important that people understand that hormones are not all the same things. Your birth control pill is not the same as your menopause hormones. The menopause hormones are lots of different hormones in different ways to deliver it. And then there are local hormones which don't go through the whole body. They all have different risks. They all have different effects. And they're all essentially important when we're having these conversations about menopause.
Yes. And it's so important to have someone like you so that they can help figure out what would be best for the patient. And then from a physical therapy perspective with regard to hormonal mediated vestibulodynia, what we see is that the patient can basically more or less grip the muscles or contract the muscles because of the discomfort. And then that becomes like a habit. And then they have two issues going on, which they need to see Dr. Rubin for the hormone, like the cream, and then
the tissue,
also
right? The tissue
the
problem,
tissue,
and then you do the muscle.
tissue problem, and then the muscle problem. And the muscle problem is where we complement each other so well on healing these patients, because we can heal them. So to more questions, how do hormonal imbalances like PCOS, thyroid issues, how do they impact sexual and pelvic health?
Yeah, I mean, I think there is a lot we don't know. And that's why, again, it's really important to look at the whole person, and then also work with different clinicians to really try to optimize whatever it is. I think PCOS has a little bit of a bad, first of all, I mean, you wrote a book on endometriosis, so you know how insane it is in 2024, how little we know about women's health conditions. I mean, I'm a urologist, I'm not a gynecologist. And when I start probing questions about PCOS and I get these bullshit answers from people of like, well, we don't really know this and we don't really know that. I was like, do we know anything? Like, can we definitively say anything about PCOS? And I don't know that we can. I think that we've blamed testosterone a lot as being the problem, but I'm not sure that that is actually the true story. I think there's a lot of insulin resistance that we're starting to understand. I think everyone with PCOS doesn't all have PCOS and doesn't all have the same problem. And I think, unfortunately, we have had decades now where our only solution is birth control pills. And so it has stopped. It's literally a brain drain because it has stopped research into helping find other treatments, other therapies, other things that can help people using their natural hormones that are happening, or more natural hormones. And so everything, again, when you play with hormones, there are consequences. So you, of course, can have effects on your sexual health if you have PCOS or endometriosis or PMDD or any of those things. And it really takes, unfortunately, it's not a one size fits all of everyone with PCOS take this pill and they will be, they will be sexually happy. You have to really work with someone who knows you and knows what's going on in your body to the best that anybody understands it. And is willing to try different things with you.
Yeah, I agree. So you explained very well before about like local symptoms in the vestibule that patients may feel if they have a hormonal imbalance, like the cayenne pepper type feeling, you could have itching, rawness type feeling, and what to do in those scenarios. What are some other symptoms, probably more like systemic symptoms, that you would identify as having a hormonal imbalance or contribute?
I mean, this is where, we have a new term that we've started to use, which I think is really cool. There was a paper published recently this year called NFLM, not feeling like myself. And I think it just captures it so beautifully because every woman in their late 30s and 40s, I literally had my best friend from middle school call me just before we did this podcast being like, what in the actual hell is happening to me? I'm a very smart woman and I don't know what it means to lift weights and eat protein and like get sleep and like what the hell is happening in my body? And that is what's happening is you have all these smart, really capable people and they're falling apart. And it's not their fault and they can't yoga their way out of it and they can't pay their way out of it for an easy fix or one pill. And it's understanding what are the symptoms. And they can be so variable and everyone experiences this differently. So it could be dry eye. It could be changes in your hair, skin, and nails. It can be your sleep goes to hell. It can be a frozen shoulder or, a plantar fasciitis, which we're now terming the musculoskeletal symptoms of menopause or syndrome of menopause. We see a lot of dryness. We see urinary tract infections pop up around now. Pain with sex starts to happen for some people. There are a gazillion symptoms because you have hormone receptors in all of your body. But we don't teach all doctors about hormone receptors and how hormones are important for the body. So it's a nightmare because our patients are going to 12 doctors. You go to your cardiologist for your heart palpitations. You go to your neurologist for your headaches. You go to your orthopedic for your frozen shoulder. And none of them were taught about perimenopause. They literally will say to you, this happens sometimes in this age group and we don't really understand it. So here's anti-inflammatories or here's a big workup, that shows that you're fine, lady, just suck it up. And so it's kind of a nightmare we're living in because we don't teach doctors about menopause. Literally, the studies show that less than 6% of doctors, and this is OBGYNs, get any training whatsoever in menopause. So welcome to the nightmare. Glad to have you. And so you actually have to find your information from Instagram and from podcasts and from doctors who deeply care about these issues. And you have to educate yourself because you have to learn how to advocate for yourself.
Yes. And you have been a pioneer in and as well as the Ishwish crew and many more people as well with the term JSM.
GSM, genitourinary syndrome of menopause. Yeah, GSM.
Yes, I'm not always good on the spot, but that's okay. Yeah, GSM, you taught me a lot about that. So we're on a track, but we still have a far way to go. So
it is a problem because many of us are in this echo chamber, and so we all follow each other, and we're like, this, and then you step out of the echo chamber and you realize nobody knows it. And so, keeping with, my colleague now who's seeing patients in our LA office, Ashley Winter, she's like Twitter's favorite urologist, and she talks all day, every day about vaginal estrogen and the benefits of vaginal estrogen and preventing urinary tract infections and helping with pain with sex. Guys, we've had vaginal estrogen since the 1970s. It's been around. It works great. It's as good as Viagra for women, and yet it's not being marketed or prescribed appropriately. And so it is the simple that actually turns out is the most important thing. We just published a study that showed if people in Medicare used vaginal estrogen appropriately, like they should be doing, we would save Medicare between $6 and $22 billion a year. Billion.
Wow. Well, from what specifically, though? Because of
UTI prevention.
UTI and incontinence, right?
Yeah. Like we didn't I don't even think we used incontinence. Like that would probably triple the $1 billion. Yeah. But for UTI, for hospitalizations for urosepsis, for urgent care visits, prescriptions for antibiotics, antibiotic resistance, $6 to $22 billion. Yeah, wow. If we added incontinence in there, like it's like I can't even imagine a number that high.
Yeah, that's crazy. So speaking of the incontinence part, how do you describe to patients how pelvic floor function or dysfunction helps with sexual response?
Oh, it's so important, right? Like the pelvis is a sexual area, like the whole area, right? The clitoris, the vagina, like this is all sexual anatomy. And so as it changes, if you have a watermelon come out of your vagina or your abdomen, it's going to change your sexual anatomy. If you have the vagina or the uterus prolapse or fall down, it may change your sexual anatomy. If you have hormone changes, it's going to obviously change your pleasure and your sexual anatomy. And when you leak all the time, when you cough, laugh, or sneeze, or when you feel urgency, that doesn't feel very sexy for most people. And so that can affect your confidence in your sexual health. And so I'm a big believer of whatever is bothering you or if it's affecting you, it is a problem and it deserves a solution. And so we have a lot more doctors who can take care of prolapse and incontinence than we do doctors who take care of sexual health. But you find that when you take care of the prolapse and incontinence issues, that can help with sexual health, of course. There's often more to it than that, which is why we're often teaching those doctors and educating and lecturing those doctors that we got to care about more than just those things. But it's a really good beginning.
Yes.
No woman
agreed.
should be suffering with incontinence and prolapse. There is so much that we can do to help them.
Yes, I agree 100%. So what would be some of the risks, if there are risks, with hormonal therapy?
Yeah, so again, there is a difference between hormones locally for the vagina to prevent urinary tract infections, and those really don't have risk. And so you may see an occasional yeast infection when you start the therapy, and that's because the vagina is getting more acidic. And as the microbiome shifts, sometimes you get a yeast infection, you treat it, you keep going, it goes away. But sometimes you see people not like a certain modality. So we'll have patients who say, well, I can't take vaginal estrogen. I tried it, it didn't work. Well, maybe the cream was irritating and it didn't work for you. So why don't we try an insert? Why don't we try a different product? So you got to find the right modality, the right product. And there are inserts, there's creams, there's rings, there's different things that you can do. Now, systemic or whole body hormone therapy, that gets into a little bit more nuance because there's a lot of different ways to give it. So you could take a pill by mouth, you could do a patch, you could take a gel. Like there's different formulations. A lot of patients on the internet talk about pellets, which we don't do, but a lot of people out there do and charge way too much money for. And it's not regulated by the FDA. And so there's a lot of different ways to do whole body hormone therapy, which means there's a lot of different risks out there that you got to understand. And so that's why, again, you have to work with a hormone special, like a menopause specialist. Like if your doctor's only offering you one type of hormone therapy at a high price, that's not the right person. You need someone who says, well, here's the menu, right? There are pills, there are rings, there are creams, there are injections, there is, there's all these things. Here's, what's right for you. Because a pill of estrogen does have an increased risk of blood clots, but a patch of estrogen really doesn't show a significant increase of blood clots. And so we do a lot of counseling and educating patients. We also spend a long time talking about how we don't know everything. There's a lot of things we don't know. And so the other part of it that no one talks about is what are the risks of not taking hormone therapy, right? If you choose not to take hormone therapy in menopause, you may be at an increased risk of osteoporosis. You may be at an increased risk of heart disease. And so not doing things have significant consequences. And we don't really talk to women about that, nor do we often give women the choice to say, here's what we know, here's what we don't know. What do you want to do with your body? How do you want to live today? How do you want to live in 5 years, in 20 years? How do you want to age? Because I'll tell you, I want to be a woman at 90 who can take a suitcase, put it over the overhead when I'm going to Hawaii. Like that's what I want. If I'm going to work this hard now, I don't want to be with dementia in a nursing home, living out the years, trying to remember the podcast that I was on in 2024, right?
And what about, that's hilarious. I love it. I feel the same way. What about our pregnancy population and our postpartum population and those that are breastfeeding? Are there, I know you may not, do you see a lot of pregnancy?
I saw one yesterday. I saw a patient with a 3-month-old yesterday.
Yeah. And they're suffering too. Like, what are some of your suggestions for them? Because they fear any type of hormonal therapy. They don't.
So we're doing a big push right now for that population. We just coined a term GSL, or genitourinary syndrome of lactation. We just published a paper on it. And we have a whole team of students who are actively working on a research project right now, sort of looking at it from multiple angles. And what I told our students, and we have what we call ourselves the sexual medicine research team, I said, it's not enough for you to publish papers. You got to publish the papers, you got to do the research, but I need you, as you're thinking about that, doing outreach campaigns, doing advocacy campaigns, getting handouts in doctors' offices. You need to think globally about all these sort of problems. So we're working on it. But really what it shows, like when you're breastfeeding, you're menopausal, right? Like your hormones are essentially that of menopause, but it's not forever usually. But for some people, it might be 2 years or 3 years. And so it can come with low libido, it can come with vaginal dryness and urinary tract infections. And so the data supports the use of vaginal hormones in this population. There is actually no data point on earth to show harm to milk supply, to show harm to systemic blood levels, to show any harm to the baby or the mom. And it's really, we have that data. It's really how that data is disseminated. It's how that data is used. It's how that no one's talking about it. No one is telling that to their patients. They're saying, oh, only if you really need this should you use this. That's insane. Because at the 6-week visit, every gynecologist is talking about birth control. And birth control is like giant nuclear bomb amounts of hormones. And so they literally are saying you can use nuclear bomb amounts of hormones that have slightly increased risk of blood clots. That's safe for you to do because we don't want you to get pregnant right now. It won't affect your milk supply. It won't affect, your ability to take care of your baby. Here you go. Here's the prescription at 6 weeks. Vaginal estrogen, which doesn't go in your blood supply, which doesn't affect you at all. It's like a minuscule dose. No one even brings it up. Like, you can't make this stuff up. It's outrageous.
Yeah. I really appreciate you encouraging the students and the residents to really get out there and advocate. That's why we have you on here right now, because we need more people like you advocating, spreading the word. These poor pregnant postpartum women, they're feeling like it's all in their head and they're crazy and it's all because they can't sleep and whatever else because of the baby. But part of the not being able to sleep is this hormone dysregulation as well. So we appreciate all that you're doing.
We got a lot of work to do. And it can't just be me, which is why we have to be loud and bring others up with us.
Yes, agreed. So let's get into more of like how you can support hormonal therapy, or if those that choose not to do hormonal therapy, through diet, exercise, stress management, and how that can affect hormonal levels, but also sexual health.
So it's really important that people take care of themselves and that they take care of themselves. Self-care is not taking a bubble bath and getting a massage once a year. Like, that is very pathetic if that is your only sort of self-care. What is important for self-care is educating yourself. That's probably the most important thing, in knowing that your body deserves this, that you as a human deserve the best evidence that exists on how to live as long and as healthy long as possible, because just living the numbers is not living your life. My mother-in-law, who's in her mid-80s, said to my husband on the phone last night, you really got to start exercising, because you don't want to be like me, who never exercised enough, and now I'm feeling it, right? So it is like look towards the old people that you see and say, do I want that, or do I want Betty White, or do I want what's her Dolly Parton at the Super Bowl? Like, is that how I want to age? And so what's going to get you there? Because it is going to take self-care to get you there, and self-care means getting the right medicines and hormones in your body to keep you as strong as possible. It means lifting weights so that you can build muscle and that you can prevent the bones from breaking down. It means fueling your body with nutritious food that build protein, that build muscle, that is real food, that you don't starve yourself because you want to fit into bikini, but that you feed yourself healthy food so that you can put that suitcase over the overhead compartment at 90. And so sleep, we have to get you sleeping. And sometimes you need progesterone in order to sleep enough, because if you don't sleep enough, you will die earlier, right? Like, you will not have a brain that is capable of sort of healthy living. And so I think that's the change in self-care. It's no longer, should I put Botox in my forehead, and do I need to do my juice cleanse? It becomes, how do I want to invest in my body, in my mental health, in my physical health, in my nutritious health, in my hormone health, to maximally live life to the fullest? And I think that's the paradigm shift that we need to start going after.
Yeah. And it doesn't have to be expensive either. it could mean just, going out for a walk every day, but really like trying to get your heart rate up if you're not feeling up to it. Definitely always listen to your body. If you're not feeling up to it, take a slower walk or do a little yoga at home. There's definitely free yoga YouTubes these
In
days
the
or
era of YouTube, it is no longer, I can't do this because I don't have money, right? Lifting soup cans to get muscles is better than doing nothing at all. And so I think and luckily people have podcasts now, so you can put us in your earbuds and go for a walk around your neighborhood, right? Like these
yeah.
are the things that you can't, and it's hard. I know it's hard. Like for me, I don't have an hour in the day to exercise. I have small kids. I have a busy growing practice. And so I made a commitment to myself. I'm going to do 10 to 20 minutes, 2 to 3 days a week. And it's all I can do right now, but I've now done it 89 weeks in a row. And so, right? Like it's good, but it's 10 to 20 minutes, 2 or 3 days a week. I'm not running a marathon, people. And so, but because I've done it so consistently, I now see myself of like, ooh, I want to eat more protein. I feel better when I do this. And
Yeah.
I actually on the weekends want to do a 30-minute thing because I actually enjoy the way that I feel when I do this. And so it gets a little addicting in that way, but you don't have to be intense about it. You don't have to be a bodybuilder or a rich person to do it.
Yeah. Yeah, there's so much more about just like functional training now and basically using your own body weight to do exercises. So definitely search on YouTube how to use your own body weight to do exercise. And how would you say like stress can impact hormonal levels and sexual
Yeah,
health?
so not having hormones in your body can really increase cortisol and inflammation and all of that. So we're only just starting to understand all of these things. And so for me, I always want to prevent problems from happening as opposed to see people when they're at their worst. But we'll see people when they're at their worst. It's funny. I have a patient I'm thinking about right now. She came to me she worked at Google. She was at the top of her game and she got COVID and she sort of went on this whole long COVID journey. I have POTS, I have long COVID. And she came to me a shell of a person. And she was 47 or 48. And we listened and I talked to her and I heard her and I validated and we got all of her medical history. I said, I totally understand. And we said, what if we help supplement you and support you with hormones? Because the hormones are just going crazy in your body right now. And so that's going to help your POTS. It's going to help your long COVID. It's going to help support and put some gas in your gas tank. And she's like, oh, I'm afraid of hormones. My mother had X, Y, and Z. I can't do X, Y, and Z. And we again educated as much as possible, met her where she was. And I just talked to her a few weeks ago and she is back at work. She literally said to me, I couldn't believe this. We had done a virtual call and she said, I feel great, Dr. Rubin. I just need my refills. She said, I just started dating someone. I love sex again. I'm so happy. She didn't mention POTS. She didn't mention long COVID. She didn't mention how tired she was. She looked like $1,000,000. I gave her estrogen, progesterone, and testosterone. I gave her 3 things. She does not spend very much money on these 3 things. The testosterone's $9 a month. The estrogen's covered by her insurance and the progesterone's covered by her insurance. And she was a new person. And I said to her, I said, no one believes me when I talk about these patients. Like no one believes. She goes, Dr. Rubin, I didn't believe you. I can't believe how good I feel. And she said the magic words. She said, I feel like me. And it was just like, that's the best, right? And so these things that we're seeing so much long COVID is the inflammation that's happening because your body is so hungry for healing and it doesn't have the right hormones, to help you heal. And so we have to be doing more research on the intersection between perimenopause and long COVID and all these things. So we got a lot of work to do.
Yeah, we do. And speaking of a lot of work, you have been instrumental in research in these areas of women's health, sexual health, and pelvic health. Are you working on, I'm sure you are, but I should say, what are you working on these days with regard to up and coming research?
Yeah, we're doing some work in genitourinary syndrome of lactation. We've got a nice project going right now about orgasm and how doctors have no idea how to talk to patients about orgasm. There's no framework, there's no proper questioning, there's no questionnaires that actually work. So how are we supposed to gather data on orgasm when no one's even asking any of the same questions? We have data on some rare sexual health conditions that we're doing a lot of research on, something called post-orgasmic illness syndrome. We have a ton of projects that are going on, which is so fun to have this research team. One of my favorite projects we're doing right now is on the labia minora. So these labia minora, when you're a baby, you don't have them. You grow them in puberty and you lose them in menopause. And that's all we don't know anything about the labia minora. Is it estrogen? Is it testosterone? Can you grow them back? Does everybody lose them the same way? No one has even begun digging. Literally all the research we have is when people want to cut off their labia to look more like porn stars, which don't get me started. There is such a lack of research on this part of the body. So we're trying to change all that. And again, there's so much work to do in this space that I have been able to train a doctor who's coming to join us in September, who's has appointments available if anybody needs. We have another doctor who's joined us. We have Dr. Winter out in LA. And so my dream really is to start a fellowship where I can train doctors at the highest level to do this, because you can't just take a weekend course and be the expert in this. Like, you have to be obsessed with it. You have to be obsessed with it, and you have to want to do it and learn. Like, I actually think that the definition of the expert is the one who's willing to say, we don't know anything. Like, what if we try X, Y? Here's what we do know, but we don't know X, Y, and Z. And those are the doctors that you want to surround yourself with, the ones who are curious, the ones who know what we know, but also know what we don't know, and are both willing to try things, but also willing to push the science.
Yeah. I would love to see a research, and I am not as research savvy as you are by any means, but research on how, if we could do hormones with pelvic floor physical therapy and how that improves the orgasm.
I do
That
too.
would be
I absolutely want to do that research.
Yes. So what are some other resources or support networks that women can find more of this information? Because as we know, there's a lot of misinformation out there. So what do you recommend, ISWISH included?
Yeah,
And then
so for
for
anyone
those,
with pelvic pain, I'm obsessed with the organization called Tight-Lipped. It is a patient advocacy organization, and they are doing incredible grassroots work, going door to door to residency programs to try to teach doctors about how to examine and diagnose pelvic pain conditions. I love what they do. So if you are a patient and you want to feel your voice is heard, get involved, because they need your help. If you need to find a clinician, ISWISH, ISSWSH.org is a great way to find a provider for sexual health. If you need to find a menopause provider, menopause.org is a great resource to find a provider. There are doctors like me who are on both websites, and that's really important because you see a lot of the intersection between the two. And then if for male pelvic health, I'm on this website as well, which is the Sexual Medicine Society of North America, or smsna.org, is you can find someone who's interested in male sexual health.
amazing. And if you're looking for a pelvic floor physical therapist, there's the APTA, the American Physical Therapy Association. I believe ISWISH, that you mentioned earlier, has physical therapists on it as well as I think Pelvic Guru has physical therapists, pelvic floor physical therapists specifically. So this has been amazing. Can you tell our listeners how they can find you, and again, where you are located, and do you do virtual?
Yeah, I would love for you to sign up. We have a great newsletter on rachelrubinmd.com. I would love for you to sign up on our newsletter. You can find us on social media at Dr. Rachel Rubin, and our LA office is taking new patients. We're taking new patients in our DC area office. We often like people to come in and really experience what it means to sit with someone and really get a deep, in-depth visit. And so we try not to do the first visit as virtual, although again, we're actually finding innovative and new ways to treat more people and find new ways to help people. So that's where the newsletter becomes really helpful, because I'm really trying to do more, and the more that we can do, the better. And so if you're in California, please reach out. If you're in or willing to travel to California or the DC area, please reach out and follow along, because you deserve this type of level of care. Everybody does.
Yes, I agree. We need more of you in New York City, by the way. So if you ever want to branch up, I know we have Andrew Goldstein, but he's just one person. New York's huge. So thank you so much for this wonderful podcast, and I hope to see you soon at Ishwish. And this has been amazing, and I hope the listeners definitely look at Dr. Rubin's newsletter. There's a lot of wonderful information there, and I look forward to seeing you soon.
Thank you so much for having me.
Thank you.